Hi everyone. So my name is Arunah Chandran. I am a public health officer at the International Agency for Research on Cancer. We are a WHO specialized agency that focuses on cancer, and my work, and especially for the talk today, I'm wearing my hat on research for implementation. Hence, I'd like to take you through some of the context, or at least applying the lens of context to improve outcomes in cancer early detection. So I promise not to be draggy. There's only two things that I'd like to speak to you about today. So what are the contexts that we all maybe need to be aware of when it comes to cancer early detection? Secondly, how do we assess this context, and how does implementation research play a role? So just two things. You might have heard this from Prof. Wu earlier. Unfortunately, I wasn't able to follow the conversation of her talk earlier, but I wanted to just quote something that our Director General, Dr. Tedros, tweeted several months ago. Every 2 minutes, a woman dies from cervical cancer. Although the knowledge and the tools to prevent and even eliminate this disease already exists. So just take a step back and think about this. We have the knowledge and the tools, but vaccination, screening, and treatment are still not reaching the scale that is required. And one can't help but wonder why. So this gap between knowing what is the right thing to do and actually doing it it has a name. It's actually called the no-do gap. And there are studies that show that this no-do gap can be anything between 17 years. And that's actually a unifying sort of challenge for translational research, as well as the raison d'etre, or we call the reason for being, for implementation research. Recent studies show that this gap could be anything between 15 years, but we know from public health crises such as COVID-19 that the gap can indeed be a short one. So now that we know that there is indeed a no-do gap, let's look at some of the challenges that we face in cancer early detection. So I extracted this out of the National Health and Morbidity Survey key findings of 2023. And you would see that the screening pattern in Malaysia still remains suboptimal. The numbers speak for itself of the people who did not or never had a screening done, whether it's for a mammogram or cervical screening or even for colorectal screening programs that currently exist in the country. Now, our colleagues at IKU went one step forward and they asked people, why is it that they do not attend health screening? Most of them said that they felt healthy. 80% said they didn't have any symptoms, so why should they go get screened? And quite a number said that they had a time constraint. So these are some of the sort of barriers that an individual faces as a service user. But then there's always other sort of levels of opportunities and barriers that exist, not just at the individual level, but also at the service provider level. And then if you look at a wider sort of perspective, the health systems barriers. And so these are something that is very, very multi-dimensional, I would say. This is what I'm showing you on the screen is one way of looking at it, where all these opportunities and barriers can actually affect some of the cancer care pathway, for example, in early detection. For example, I've put there screen delay. If somebody does not feel that they are ill, or if they're totally healthy, why should they go and seek healthcare, as you would put it, in screening? So that's a question. If somebody was feeling their first symptoms, what is the reasons behind the access delay from the time they actually felt that there was something wrong with them to going and seeking care, taking that first step, and so on and so forth. So this may be pre-diagnostic delays, diagnostic delays, or even treatment delays. So there are, like I said, there are multiple ways of looking at the cancer care pathway, and this is very, very multidimensional. Another way of looking at it could be, for example, from the health systems or the building blocks perspectives. Now, we must always take a step back every time we face a challenge, right? And think about, is this what we're seeing is it because of overuse of our services? Is this underuse or even a misuse of our services? Now let's go back to the image that I showed you earlier. Think about it. If people or individuals or the general population are not attending screening, is this because there is an underuse? Could that potentially also be an issue of misuse or even overuse that we don't see in this image? A lot of the programs in the country at least now collect, for example, in forms of coverage, number of tests or number of screenings that are done for cervical cancer screening, for example, amongst the women. But this does not really reflect how many women actually underwent the test, if they're undergoing the test in the right intervals, if they are doing one too many. So there could be multiple sort of implementation challenges when it comes to really cancer early detection, whether it's underuse, misuse, or even overuse. And then the next thing that we think about is who or what is really affected in this whole cancer care pathway. And so that is some of the context that could potentially exist in this cancer early detection. So I said I would be touching on the second thing. The second thing is, how do we really assess this context, and how does implementation research really help? I would like to illustrate this by taking you through one of the projects that I have the pleasure of coordinating in a rural population in India. So if you see in that map, I'm sorry that's not a very clear sort of picture, but the Access Cancer Care India project that we currently coordinate at IARC involves 3 very different states, 2 southern states and 1 sort of northern states with very, very diverse implementation ecosystems, whether it's logistics, whether it's political, social, or even economic. And our aim is to design and evaluate a strategy for cancer early detection that is actually integrated and contextualized to the local health system. And what is our implementation challenge really? Well, if I can name 1 or 2, for example, late stage presentation, women or people who actually eventually may get an initial diagnosis but don't follow through. I wasn't able to hear Prof. Wu's full presentation, but I heard what she said I think in the beginning of her presentation. She said, what's the point of screening if there is no follow-up? So that's one of the major concerns or implementation challenges that really exist. Some of the screening strategies currently are not suboptimal. So with that being one of the some of the key challenges, we started by actually mapping out who are really affected by all this. There's a long list of stakeholders who are really involved in the cancer care pathway. The second thing that we thought about is, how do we go about assessing some of the implementation challenges in the people or among the people who are actually affected? So for some of the individuals, for example, we used a survey approach. You can use multiple different ways of assessing this. For example, for the community groups and community health workers, we took a focus group approach to build up upon ideas and hearing problems and solutions in a group. For clinicians, program managers, we used an in-depth interview approach. And for the health systems perspectives, we looked into an in-depth policy analysis and conducted facility visits. Took all this, put together, triangulated all this information and created a SWOT analysis, and subsequently worked with stakeholders to co-develop solutions that we hope, and we're at this stage right now, that we hope to be able to monitor and gauge whether there's the successes or failures, not just through numbers of uptake, but also whether are these solutions now acceptable to the people who really matter. Is this going to be cost effective? What about the fidelity? And when I mean fidelity is here, were the interventions or solutions really implemented the way they were supposed to? And very, very most importantly, whatever we do now, when we exit the project, will the health system be able to sustain and scale whatever that we're proposing? And what about some of the desired outcomes that we would like to think about for our project? So this was basically the overview of the work that we went about to assessing context and using the context to develop some of the solutions. And so The very first thing that we did was go and ask the people. And that picture is our project manager Subhashini, who went around to the district that we were interested in, to 400 different households, asked people what is it that they thought about their health, how do they really access care, what they felt were the barriers and opportunities that are out there to improve their screening behavior, and most importantly, how can we help? The next, we went to the patients themselves and said, how was your journey like? Did you experience any delays in care? Were there any, for example, like I said earlier, were there any sort of delays in care in terms of screening? Or was there any issues in access to care? What were their main barriers? What really helped? And if they would be willing to share their experiences so that future patients who go through that similar journey can have a better experience than they did. The next thing that we did, so this is Ranjita. Ranjita is a community health worker who works in a very tribal village. Even to get to this tribal village in the state of southern India will take you 3 hours from the main road. So we asked the people who are the core essence of the care system, the community health workers, how do they feel about their current work? Are they open to learning some innovative solutions? Again, how is it that we can help? And this is a focus group discussion where we gathered all the women together, where they could build up some of the ideas and hear about some of their grievances in their current screening pattern, and how they felt, again, they could sort of contribute. And people were very proud to come and say, these are some of my problems, and here is how I think we could do this. So next, we put all this together and we brought this to the stakeholders at the sort of policy and program management level and asked them, what is it that you really think in terms of managing your cancer early detection pathways? What are your pain points? And what are some of the solutions that could potentially work? And how can we sit down and refine these strategies together? Not just that, there is also an opportunity to go out to the community back again and say, now look, we've asked all these different people and we have a list of potential solutions that we think you should sort of think about, and if you could help us sort of refine that better. In this picture, we sit together with some of the community health workers and we try to map out a pathway that they felt would work best for their own community. Now, the tribal community said that this would work better for them. They thought a community-based approach for screening would work better, but the urban the communities in the urban slums said, no, actually, we would prefer, there is a primary care clinic next to us, and we would prefer to actually go and visit this facility. And so we sat down and mapped out the potential pathway that would work. Now, this is very resource-intensive work, but it's definitely work that is rewarding. Now, we go back to that initial framework that I presented earlier. So if you see in the stories that I sort of took you through, we went through each of these different steps to actually come up with some of the strategies for implementation of the interventions that have been proven elsewhere to work to the rural Indian communities. Along the way, we developed tools, right? So I spoke about policy assessment and healthcare capacity assessment, health system capacity assessment, where we went back to see if there was a standardized way to do this. We didn't really find anything that would work for low middle income countries, so we went ahead and created one. This piece of work is currently under press, and I'll be happy to share with any one of you if you're interested. Just reach out to me. I'll be sharing my contact details afterwards. Some of the other tools that currently exist at IARC is a tool to assess context from the perspective of health systems. How do we assess barriers to effective cancer screening, and what are some of the solutions that exist? We just don't want to go and see these are our problems, but we want to be able to say, hey, these are some of the solutions that have worked elsewhere that might be worth for you to explore in your own setting. Now, the framework or the process that I've actually explained to you, I took it from a perspective of a low middle income country. Perhaps that's useful for breast survival and oral cancer screening, but this sort of process would work anywhere. It would work in a high income country. It would work for a different sort of cancer screening. So I work on a different project in the European setting where we're trying to now reinvent prostate cancer screening. Let's look at what is the implementation challenge here in Europe. Now, we've traditionally used PSA testing for prostate cancer screening. The problem with that is PSA testing detects low volume, low-grade cancers as well as the high-grade ones. What happens to this is there's a risk of overdiagnosis, there's also a risk of overtreatment that adds additional costs to the healthcare system and also impacts the quality of life of men. So one of the solutions that was proposed was this. So what went from, if you don't get confused, it's a very complicated flowchart, but in the first sort of column you would see that there is a PSA testing, and then in the last column that you would see this diagnosis, treatment, and follow-up, what was traditionally the way of doing things for prostate cancer screening. What then we are now proposing is to add a layer of risk stratification as well as, for example, you see smack in the middle of that diagram, there's an MRI and then there's another risk stratification, basically adding layers of risk stratification so that the amount of men who have raised PSA who will actually reach a biopsy process are reduced. Now, we are trying to implement this in very different settings. You would see the sort of geolocations there. Ireland, Spain, two very different regions in Spain, in Wrocław in Poland and Vilnius in Lithuania. Now, this is exactly what we want to do. We want to implement a prostate cancer population-based screening via PSA testing, followed by risk stratification, an MRI, and biopsy. How difficult can that be? Very. Especially when your health system are organized very, very differently. In Spain, there's simply not enough urologists to run this program in their setting. In Ireland, there is no buy-in from the GPs to already add on to the amount of screening work that they already do. In Wrocław, there are some satellite screening centers that could potentially be utilized. So what are the important things that we need to to sort of imagine here is that context is crucial. And we can apply the sort of diagram or the framework that I spoke about earlier in any of these settings. And that's exactly what we did. Look into the tools that we had to look into the healthcare capacity. We asked the clinicians, what was your workflow like? And to develop the strategy for implementation of that algorithm that I showed based on capacity assessment was very, very important for us. Now, I don't have a key takeaway message, but I hope in the last 20 minutes or so, I've sort of taken you through some of the context that it currently exists in cancer early detection and some of the ways through implementation research that we can actually assess it. I just want to leave you by asking a question. How can we, as either public health researchers or public health people who work in implementation, whether you are a cancer organization or you are ministries of health or you are really the service providers, how can we make the choice to undergo cancer screening the easy and informed choice? And I think that is what we are all aiming here, taking into account the context that exists, the context that varies between all of us. With that, I'd like to thank you. Here is my email address. If you'd like to get in touch, I would love to speak to some of you about some of the work that we're doing in the different areas. If you scan the QR code, that would lead you to my LinkedIn where we can connect and speak more. So thank you.
Thank you, Dr. Chandran. So now I would like to invite our speakers today to the stage in front. And I will open the floor for questions. For those who want to ask questions, please raise your hand. Anyone? Questions? Maybe I shall start asking Prof. Wu. So just now you mentioned about the 90-70-90 goal, right? So I believe our audience here is for multiple stakeholders. There are physicians, healthcare providers, community representatives, even those who are involved in policy making. So how do you think that we can contribute to this, to achieve this 90-70-90 goal?
I think what I've said complement what Arunah says. It really is at the sort of foundation is, I think trust is very important. So people need to understand that these vaccines work. They need to trust the communication that goes along with it, because there's a lot of misinformation. We know we need to get 90% vaccinated. Our government has rolled it out. It's easily accessible in clinics. We need to think about financing. The second pillar is the toughest. The second and the third pillar is the toughest, and that's where we need to make it easy. We need to understand value and context in the Malaysian setting. And even Malaysia is very heterogeneous. If we go to Sarawak, the challenges are completely different from Selangor. And that's where you need Sarawakians to champion Sarawakian context, and Selangor to challenge, to sort of work on Selangor context. That's why we can never depend on just one institute, one agency, and it needs an all-society approach.
Can I add, I like your approach about language, approach to the patients when you entice them to do these tests. Because we doctors, we use medical jargon and we frighten our patients. So approach how you talk simple English or simple Malayan makes the patient feel more comfortable. This, the emotional intelligence of doctors is missing. And we frighten our patients. Another point I'd like to mention, Dr. Arunah, lately European endocrine related cancers have come up with new biomarkers for CA prostate. So they're using ghrelin acylated transferase, they call it GOT, and they found it in the tumor cells of the prostate. This biomarker is very high. So I think very soon, instead of depending on PSA, we can measure urine GOT as well as plasma GOT, which would be much easier than depending on PSA, because there's the positive and negative of positive, negative positive area where PSA you think it's high, but it's missed and overlap. So it can be actually missed.
Yes, question. Hi everyone, I'm Prof. Aisha from UM. Hi Yidling. And hi Arunah, I always heard about you but never met you before.
Aisha, I actually, I see you but I can't hear you.
Oh, okay. Can you hear me now?
Yes.
Yeah, okay. So thank you for that presentation. I think Arunah, you really sort of conceptualized the whole thing, and I think the people in the room, which are the multi-stakeholders that we have around the country, so I think this is very crucial, because I think people are not remembering that you need an ecosystem to actually get something moving. And we are always inculcated with this ego system. So if you want to be really a champion in something, you'll be doing your own niche area and you're very siloed. So I think this generalism of actually finding out how to actually sort out things together would be the key feature. So now my specific question is for Prof. Wu. What is the role of the general practitioners? And I think in the health white paper, we are very keen to enhance primary care. But I find that actually trying to engage the private GPs in the Robom project was actually very, very difficult. What are your thoughts on this? And what is the role of GPs in eliminating cervical cancer? Thanks.
I think tertiary healthcare and ministries need to become friends with our private GPs. I think they are working in silos, and so we need to be more inclusive. We need to remove this them and us quite a lot. I mean, for our private GPs to even refer cases to us in the hospital is such a difficult thing. There's no ability to get in touch with one of us. You ask our private GPs, if we call Prof. Aisha, Prof. Wu, they don't know how to contact us. So I think these are the simple things we need to ensure that we can link and not just navigate our patients, but navigate our primary GPs to healthcare facilities to direct traffic to us. That's something that we need to do better.
Because a lot of the GPs are still doing speculum HPV testing.
Not just private. It's actually in many hospitals that's still the case because of how the budget works in our country. Hospital budgets are different from primary care budgets. So in the context of Malaysia, Klinik Kesihatan has lots of HPV tests, but not hospitals where the specialists are practicing in. So these are the unique contextual issues that Malaysia has to deal with.
So silos, it keeps coming up. Novo Nordisk introduced and worked with WHO looking at urban areas, trying to destroy the silos. Instead of primary working for tertiary, it should be tertiary working for primary. The other way around, because this is how you break the silos. Otherwise, it's a long journey, or the word I learned yesterday, navigation, patient navigation. And they go through this journey. It's very, because to get an appointment, it's difficult. You need a specialist. You have to 3 months, 6 months. So why don't you transfer the know-how to the primary, and you reduce your waiting time instead of patient going through this painstaking journey.
All right, thank you. Any question? Yeah.
I think you're holding the mic. You can ask.
Oh. Okay. Hi. I have 2 questions. One to Prof. Wu and one to Dr. Arunah. Nicholas from ICR. Okay. So Prof. Wu, I just was very perplexed by that slide where you presented the perception of clinicians towards women who get HPV. So very perplexed, and so I was wondering, like, is there a particular root cause that is causing this perception to be inherent among clinicians? Because I don't think that's something that is taught in medical school.
No, it's still taught in medical school.
I mean, yes, but also, I mean, there is also the other side where it's not always the case, right? So, but yeah, and I was thinking, is there any evidence to show that these clinicians, like, they would be less likely, or they wouldn't want to participate in all these programs that, vaccinate women?
Excellent question. We actually designed this study and the questionnaire based on the work that was done in HIV medicine, because I realized many of our colleagues immediately stigmatize, and when they come in, HPV is a sexually transmitted disease. And then immediately it raises issues of relationship between their partners as well. It can be a real breaker for a marriage, So if the communication is wrong, this is a major issue for even rolling out a simple screening test. I didn't even show you many of the other data that was shown. We took 27 different perceptions by doctors. It is really quite embarrassing to think that healthcare professionals hold those types of view. Even things like sharing toilet may spread a virus. So you think you're rolling your head, but many of the doctors believe that, and so we have to tackle those educational issues. The second thing that sort of also has an implication for rolling out the test is that our insurance policy in Malaysia, so this touches on financial reimbursement. Our insurance companies, 14 of them now, still classify HPV test as a STD screen. So if you do the right thing, you screen with HPV test and not pap smear, and if it's positive, the insurance company will not reimburse you for the follow-up care. So that's something that we have to deal with. So when you talk about a test, when you talk about vaccine screening tests, in a wider picture, we cannot work alone. This is tackling a financial institution, which is something we need to do better. So lots of issues, even when we have good vaccines, good screening tests. These are all the what I call barriers we need to deal with.
I would like to add to what Prof. was saying. So the issue, I think, of communication is really very key. So some of the questions earlier were about how do we improve How do we get GPs to get buy-in? I think it's just not just GPs, everybody. The first thing that something or someone will think about is, what's in it for me, right? Why is it that I need to do this? I think the way we need to probably approach this is that, how do you add value to the service provider in this provision of care? I think that's something that we don't actually think about. And in terms of communication, the whole sexually transmitted disease, for example, that is associated, stigma that's associated with cervical cancer does not just happen with us. This is a global issue. If you look at some of the communication issues that's been highlighted in high-income countries, for example, Ireland has a publicly available report that just in depth into their cervical screening program. One of the patients who was interviewed said, their doctor said that nuns don't get cervical cancer. So just hearing that very raw emotion coming from a patient, who this sentence actually uttered to her by her gynecologist. So I think that the whole sort of conversation here, and something that I didn't really touch about in my presentation, is that communication is definitely key. So sorry to interrupt your question earlier, Nicholas. So go on.
No worries, Dr. Thank you.
Sorry, Nicholas, I have to add, some of our doctors, when they take a history from a patient with cervical cancer, second question they ask is, when did you start having sex? Do you have multiple sexual partners? That is the most insensitive thing doctors can ask a patient with cervical cancer.
Yeah.
So it still happens on the ground, and we do need to address this.
Yeah, I think it's high time we have to address the communication aspect. The soft skill. Dr. Arunah, I just have a last question. I was very intrigued by the co-design method that you guys employed in India, when you go down to the community and ask them how we can come up with certain programs or interventions based on feedback garnered from the various actors that you've interviewed. So I was just wondering, from all these co-design methods from the public, right, you go down to the ground, are these well received by policymakers? Because in the end, all these programs will be implemented by the policymakers or community leaders in that location. So, because sometimes there is this disconnect where community leaders think that, this is what the community wants, but they didn't think of other aspects which may hamper implementation at the policy level. So do you see this problem happening, and how do you resolve this? Thank you.
So firstly, very interesting question, Nicholas. Thank you for bringing that up. I think that's the issue. Sometimes there is always a disconnect. As somebody who comes from the outside, I feel that it is important that we are seen as a neutral convener, not somebody who is biased towards, for example, the policymaker, or maybe biased towards a certain sort of population or a stakeholder who we are addressing. It is very important that we are because I'm wearing my implementation research hat, is that I had specific objectives. I go in with specific questions that I need answers to, and my job is to put together the facts and present it to the policymakers, for example. But in reality, I can tell you that, and a lot of the colleagues in the room who are probably experienced with this will tell you that it's not an easy feat. For example, in that particular state where I showed you, we had good buy-in from the implementation, both the implementation as well as the policymakers from day one. Even before we kick-started the project, when we actually wrote the project proposal, we went to them and said, this is something that we'd like to help you with. Do you think there is room for us to come in? Do you think there is some challenges that you would like to address? So engaging your stakeholders very, very early on, where instead of saying, here is the research project, we have the funding and we need to get this done, and this is how we're going to do this. So getting buy-in from the stakeholders was very, very important. And I believe your second question was basically, how do you address the disconnect? Is that it? So that's where I think you need to be objective, because despite, for example, a lot of the communities say, oh, we need more funds. So in India, it's very interesting. They have the state health departments, and they have something called panchayats that actually govern the sort of village or district. and some funds actually go down to the ground for this various sort of, not just cancer, but it could be like various NCD activities, for example. But then they will say, oh, we need more funds to do this. But if you take back this sort of problem and say, well, actually what they need to solve your cancer screening behavior issue pattern in the ground is that they need actually more money to do activities. This is not something that's going to fly with a policymaker. They're not just going to just magically dump. So I think we have to be objective, we have to be realistic, and we have to extract some of the conversations and the gist of what we receive from your different stakeholders and sit down and say, here are some of the things that could potentially work. How do you think we can do this? Or if you have a better solution that we can be pragmatic about in this time duration. Remember, it's again, in my perspective, and it might not be the same for colleagues who are sitting there who are involved in programs, but as a project, I have a deadline. I have limited amount of funds, I have a certain amount of time to be able to complete this. So I think being pragmatic about expectations and just being objective about the outputs that you need to achieve is very, very important. I hope I've answered your question, Nicholas.
Thank you very much for all the lovely lectures which have educated me at this age. But I have 2 or 3 things. Number one, we talk about communication, and everyone said, oh, the doctors are saying this, or Fulan said this, or you said the nuns do not get. This is the problem of not communication. I think we are looking at things very superficially, with full respect. The problem is with education. It's not important that you have learned about cancer in the university. It's about learning how to live with the community to stop cancer. And this is what we should look for, to educating especially our super and superior doctors, the oncologists, with full respect to them. I myself, I was a very senior consultant for 36 years, and I've learned about it. And now I'm no longer in the medical system, I'm working in the community. Another thing, you are talking about expenses and policymakers. Tell you frankly, policymakers don't care. I'm sorry, after many years, I'm saying very frankly, because if they care, they will give you time to finish your research. If they care, they will give you more money to finish your research you need. And these are facts. If we don't look at facts and try to deal with it, then we touch everything so that we can do our work. Number 3, I think it's very important that all this project takes a lot of money, because we do not train volunteers in the work we are doing to get them to work and give them the basic pay for their expenses, not as a salary at the end of the month. I run an NGO, and I did national programs in a very big country like Oman, which has got 11 states. And I noticed that if I leave people who are working in my office and I pay them monthly salary, it costs more than if I get volunteers who I've trained, or I've got people to train them in human resource development to do the job that the people who are on salary did. And Dr. Lemke knows about it. And thirdly, I would like you to look into another type of research. We have gone through a lot. In the last 70 years, a lot of things have happened. And we are getting a lot of understanding of cancer tumors, solid tumors, liquid tumors, etc. And we are seeing that some of the tests that we are looking, for example, fecal occult blood, we have a very big waiting list in the hospital, because fecal occult blood is not the right test. It was the right test 70 years ago, but it's not the right test now. So let us see how we can change and help the low-income countries and to develop things like for colon cancer. While doing the awareness programs and going to the community, we should give them the test that you are doing at home now, which is the immune test, the FIT test, fecal immunological test, which tell you directly, even without colonoscopy. You can concentrate on it with CT scan or MRI, and you cut down your waiting list by at least 80% for the colonoscopy. the fit test. Or, for example, Dr. Lemke mentioned about the PSA. I can talk from personal experience. I have the biggest PSA test, and he knows about it. And I was really worried that I might have a tumor in my prostate, but I didn't. So why we worry people about tests that are really not giving you the true picture? So please, I beg you, and I will help you fund your research to find what is going on with this tests. And lastly, about funding, we should not leave the government to fund you. The NGOs should fund you through a PPP program, public-private partnership, where you can get for your study X number of real multiplied by 15%, because you are always wrong in what you understand how much it will be. So it is what you think is right plus 15%. That's my humble opinion from my experience. Thank you very much.
Thank you. Anyone else to add on to the speaker? Any question from the floor?
They are not very happy with what I say. I was
So hi, I'm Clara. I'm from Singapore. I'm doing community health work, so a lot of meeting different participants or members of the public and things like that. I had two informational kind of questions and then one that is a little bit more general contextual. So the first one was to Dr. Wu. I think there was a slide that was talking about how HPV 16 and 18 is going down, right, in terms of percentage, but there are some other strains that are increasing. Can I understand, is it in terms of percentage or is it in terms of real numbers? This is a very basic information question. And the second one is, I think Dr. Arunah was saying that, she mentioned something about how nuns do not get cervical cancer. That one-liner, sorry, can I have a bit more clarification on what the myth is here? Yeah, maybe these two first, and if I can, I'll ask the next question after.
Can I please take that question because I'll need to run. So after this, sorry, it's 3 to 4 o'clock a.m. for me, so I can, no worries. So the reason I brought that up was that because Prof. Wu mentioned that a lot of practitioners introduce stigma very early on into the conversation about sexual partners and sort of having multiple sexual partners, and as well as early initiation of sex very early on the conversation with the patients, and that often because of those questions, the patients or the people who actually present to the health facilities feel stigmatized. And the reason I said that was that's how one of the patients who actually presented to one of the health facilities in Ireland, this was actually a report that I quoted from Ireland, felt that there was a lot of judgment towards her, that it was her fault, that it was implied that it was her fault due to the multiple sexual partners, is that why she's contracted cervical cancer, sort of. So that was basically me showing an example of a stigmatized conversation between a provider and a service user applying the women.
Understand. So it's not so much that, I mean, the idea that most HPV infections happen because of sexual intercourse is still correct. It's just the stigmatization behind it. Is that your point?
It was the stigmatization.
Okay, I got it. Thank you.
No worries.
Yeah.
I'm sorry. Thank you very much for being such an engaging audience. I would love to stay, but I have to run. It was really lovely to see all of you here, some friends in the crowd. Bye-bye.
The data I shared with you, a 91% reduction of HPV 16 and 18 was done in a study context. We went to a community, we went to 5 different communities in Selangor back in 2013 before the women had benefited from the vaccine. We looked at the prevalence of all these types of HPV subtypes within the community using self-sampling. 10 years down the line, after they've all benefited from the vaccines, we went back to the community, we tested for these different subtypes again. and we saw a 91% reduction in HPV 16 and 18 in terms of percentage. That is because our vaccines have covered 16 and 18. But in our school programs, we've never covered 9 types of HPV. So the other types of HPV types had a trend of increase in the community. It's not that there's a type substitution or anything like that. It's just that this was an observation to say that if you don't vaccinate, you won't get that protection.
Sorry, I think my question was, is it like the percentage of the whole pie chart of infections increased, or is it like the real numbers that maybe previously we saw it was a prevalence of 1,000 and then now it's like 1,003?
Correct.
So it's the second one?
Yes, it's an absolute reduction.
Okay. And absolute increase also, right? From
Yes.
the other side. Okay. Thanks. So actually I had another question, if it's okay, which is so with so many things happening in our lifetime, like even finding out about HPV and then the vaccine and everything, one of the things that I found on my site was that people, like, they might have heard of Pap smear, but they are like, what's HPV? And then you're telling them, HPV is now better, and Pap smear is like, it's great, but maybe not as good as HPV also. And the response I'm getting sometimes is, why you all keep changing things? Like, why is things moving so fast? Can I trust that this new thing that you're telling me is good enough, or is will there be something better in the future? Or like, I just did this one, are you telling me my previous one wasn't good? There's all these things. I don't know whether anybody, like maybe yourselves or Dr. or somebody else, but have had such experiences, and how do you overcome it? Yeah.
We're living in an age where things continue to improve. iPhone 4, iPhone 16. So you buy iPhone 4 because it's the best at that time. And then 10 years down the line, we have iPhone 16, I don't even need a camera. So what you tell your women is that at that point in time when I was studying, Pap smear was the best that I had at that point in time. It was good at that point in time. But now we have molecular technology, we have HPV tests, just like all the scans you're talking about. If you talk to cancer patients, last time they only had X-rays, and now we're talking about PET scans, MRI. So you offer them what you have, the best at that point in time, but now we have HPV tests. And so communication, once again, is crucial. And the communication is that you don't need to have it done every year, every 3 years. It's twice a lifetime, or most frequent, if you have a lot of money, is once every 5 years.
Anything to add on from Dr.
Really, but as I said, mentioned, a very important message is that when you deal with cancer, it's an evolving disease. You cannot treat it once and just wait for something to happen. So follow up, counseling, so that you don't instill fear in the person afflicted with the disease. And that is the message one should take on board. And of course, emotional intelligence. Don't frighten your patients. Don't use words that would frighten them. Simple language is a caution with follow-up, because the question will arise, I'm cured, doctor. Yes, you're cured, but we have to do this processing because it's part of the paradigm of care, and what known is patient, not just patient awareness, but owning the patient. By owning the patient, meaning that you're in constant communication and giving new latest information about the care of the disease.
All right, thank you again to all the speakers for the insightful conversation for our speakers today.
Ladies first.
You're a visitor.
Just in case the man will go on,
Thank you very much. Thank you. Thank you.
Okay, thank you.
You're our visitor.
Thank you very much. I hope I did not confuse.
No, not really. No. Thank you. Thank you. Okay. All right, that's the end of the session today. Thank you. Please proceed for your morning break.